the next topic is why and when should gallbladder be removed in gallstone disease. Humera, may we have the video?
Gallstones develop when the solubility of bile is disturbed. Normally, bile contains cholesterol, bile salts, and bilirubin. When cholesterol concentration increases or bile salts decrease, cholesterol precipitates to form crystals. These crystals aggregate and enlarge into stones. Gallbladder hypomotility and bile stasis further promote stone growth. One night, a patient suddenly developed severe chest pain during sleep. Thinking it might be a heart attack, they rushed to the hospital. An ECG is performed, but the results are normal. Only after an ultrasound is done, gallbladder stones are found blocking the bile flow, which explains the intense pain. Gallbladder stones can cause several complications if left untreated. When a stone becomes lodged at the neck of the gallbladder, bile cannot flow out, leading to inflammation of the gallbladder wall. This condition is called acute calculous cholecystitis. If bile remains stagnant, it can become infected and form pus, known as empyema of the gallbladder. Continued obstruction may cut off the blood supply, resulting in gangrenous cholecystitis. If untreated, this can progress to a serious complication, gallbladder perforation. The best treatment is laparoscopic cholecystectomy, no matter how many stones are present, how big or small they are, or even asymptomatic. It's usually a daycare procedure. The patient comes in the morning, undergoes surgery, and can go home the same evening. But if gallstones are ignored, they may travel down into the common bile duct and cause jaundice, which requires ERCP along with laparoscopic cholecystectomy. If the stone blocks the pancreatic duct, it can cause acute pancreatitis, a life-threatening condition that may need ICU care. That's why early surgery ensures the best outcome.
It's my pleasure to invite Dr. Sudeeptha Kumar Swain of Apollo Hospitals to deliver the talk.
Dr. Sudeepta Kumar Swain is a highly experienced surgical gastroenterologist based in Chennai. He is affiliated with Apollo Hospitals, Greaves Road, where is the HOD of the Surgical Gastroenterology Department. He has several accolades to his name, such as the Young Scholar Award in Surgical Gastroenterology in 2015 and the Best Faculty Award from Mahatma Gandhi Medical College and Research Institute in 2010. Over to you, sir.
Good morning. Thanks, Radha sir, for organizing this and making us part of it. I am assigned to tell about gallstone disease, the cholecystectomy. So I'll go straight into the discussion. Okay. So when we see cholecystectomy, it is the removal of gallbladder in short term, like removing the gallbladder, be it by open laparoscopy or robotic. And this chole means like gall or bile, and the cystis means it is like kystis or like a bladder, which will be removed in cholecystectomy. That is the meaning of cholecystectomy. Before going into cholecystectomy, let us discuss the anatomy. Why I put the anatomy picture here? This is like commonly we in a like a normal population and paramedics, we should not compare it with kidney stones. Gallstones are different from kidney stones. The organ is different. The stone formation cause is different. The treatment is different. So you look into the basic. I am not going into the details. Like the gallbladder is like a side pouch in the biliary tract. The left bile duct, right bile duct, they connect together, form the common bile duct or the bile duct, which is called now. And the gallbladder, usually the bile goes to the gallbladder. Then there are, I'll come to the next slide. Like this is like little complex anatomy, what it looks to you, but this is what we should know little bit about it. Like the vessels, the portal vein, the hepatic artery, the cystic artery coming from the hepatic or usually the right hepatic artery, and the gallbladder. So the normal gallbladder dimension is like it can be 7 to 10 centimeter, but when it gets obstructed, it can dilate up to 50 times of it. And like the width is 3 to 4 centimeter, wall thickness normally up to 3 millimeter we consider it as normal, and the capacity is in a standard adult person is 30 to 50 ml. This is the surgical anatomy, just to know like during cholecystectomy how it looks like, the hepatocystic triangle or the biliary, the hepatobiliary triangle, and the callous triangle, which is part of it, formed by the cystic duct, the hepatic duct, and the cystic artery. So what is the function? Just because we should know little bit about the function. Why I am telling this? Because we should know when the cholecystectomy done, what happens to the function? Can it be sacrificed? That is why I told, which is different from kidney stones, where we cannot sacrifice the kidney, but in gallstone disease or pathology of the gallbladder can be easily sacrificed. It just concentrates the bile to 3 to 10 times, and in this, when there is a fatty food, the cholecystokinin is secreted from the duodenum, and the gallbladder processes extra bile to digest the fatty substance in the food which comes to the duodenum. That is what is the main function of it. So gallstones, if you take gallstones as such, 6 to 10% of population have gallstones, mostly asymptomatic. 90% of them are asymptomatic, and it varies the incidence from region to region. Like Western, Latin America, it is the highest. Africa is the lowest. ASEAN is lower than the Western countries, and 10% develop symptoms within 10 years of diagnosis, 20% in 20 years. So what happens if you look into like 40-45 is the average of the diagnosis, like 80 to 90% will remain asymptomatic. So asymptomatic gallbladder, we need not operate, that is why. And if you take the gallbladder, like cholecystectomy alone is 1.2 million, is older data in United States. Just imagine our country and the number of cholecystectomy. So if every asymptomatic gallstone you operate, this is the problem. You made the injury. Now we are mostly doing laparoscopic cholecystectomy, so 0.4% can have bile duct injury, and the consequences we all know. So anybody knows this person? He is a British Prime Minister, Eden Anthony, who had undergone a cholecystectomy, developed bile duct injury. Just imagine a Prime Minister of Britain with good developed medical service. He underwent cholecystectomy, bile duct injury, multiple surgeries that kept on like bothering him, and multiple hospital admission till he died. Of course, he died from a different cause, but this was there till death. So what is the indication where we should operate these gallstones? Symptomatic gallstones. Symptom means, what is the symptoms? Biliary colic. Biliary colic is like pain, like we were saying in the previous video, na? Right upper abdomen. Typically it stays there for at least 30 minutes to few hours. It's not just like a colicky pain comes in 1 minute and goes. Okay, so sometimes we call misnomer because it stays there for 30 minutes to few hours. Acute cholecystitis means patient has severe inflammation or inflammation of the gallbladder because of obstruction like what you saw, or because of superadded infection. Chronic cholecystitis means patient has recurrent attacks and now it is a chronic cholecystitis. Biliary pancreatitis, sometimes the gallstones goes into the bile duct and passes because you know the bile duct goes through the pancreas at the distal end. So there it causes, because it obstructs for temporary period, it causes biliary pancreatitis. Choledocholithiasis. If you have bile duct stone, you need not wait for the symptoms. Okay, there you have to treat it. Then other indications, like these are relative indication, large stone, particularly 3 centimeter stone, when it is particularly cholesterol type of stone. You know, there are various types like mixed stone is common, pigment stones, and the pure cholesterol stones. If it is a pure cholesterol stone, 3 centimeter size, there is a small chance of cancer we may consider. This is a relative indication. Porcelain gallbladder, though it's some controversy is there, but still it is considered as a pre-malignant condition and it should be operated. Sickle cell anemia, because of sickle cell crisis and the pain, it's better to operate. Immunocompromised patient or the patient who is going for organ transplantation, because there the chance of cholecystitis is very high. You should consider cholecystectomy even in asymptomatic patient. Acalculous cholecystitis particularly happens in critical ill patients sometimes, and mostly because of ischemic cause. And other causes like when it is associated with primary sclerosing cholangitis and cancer surgery patient who are going for chemotherapy, you are operating them having asymptomatic gallstone, bariatric surgery, etc. So the other rare condition, biliary dyskinesia. Dyskinesia means gallbladder is not functioning well. The amount of bile it should propel is less than 35%. That is called ejection fraction in gallbladder. Gallbladder polyps, not all gallbladder polyps you have to remove. Polyps which are more than 10 millimeter has to be with stones, or even without stone has to be. Remember, any polyp with stones has to be operated, or a gallbladder polyp more than 10 millimeter has to be operated. Then other rare varieties, typhoid gallbladder, packed stones, because this is now a pre-malignant condition, abnormal pancreatico-biliary junction with patient gallbladder, choledochal cyst, because these are all pre-malignant condition where we should consider. Because children with gallstone, because they are long standing, they will be carrying it, it is a relative indication for cholecystectomy. So other where we don't need, this is very important. This slide is more important than the previous slide. So we adenomyomatosis of gallbladder. What is adenomyomatosis? It's like a hyperplasia of the muscle, the epithelium with enlarged the sinuses, that small white dots you are seeing, ask of sinuses, and so those increase. It may be segmental diffuse where you don't need cholecystectomy unless it is symptomatic. Asymptomatic cholelithiasis, no predisposing factor for any malignancy or anything, no need of cholecystectomy. Frisian cap, where like it's a congenital deformity where we don't need cholecystectomy. Small GB polyp, 3 millimeter, 4 millimeter, incidentally diagnosed during health checkup, no need of doing cholecystectomy. Cholesterolosis is called strawberry gallbladder, like cholesterol esters are studied on the wall of the gallbladder. We find that during a routine checkup, no need of doing cholecystectomy for that. So what happens after cholecystectomy, just to know a little bit, the bile ducts mostly takes over the work of gallbladder. It dilates a bit and forms as a reservoir. The bile acid synthesis and recycling get accelerated, and initially some of the people develop some discomfort, bloating after cholecystectomy, but most of them become normal. Only in small percent, like 1 to 5% or maybe little more in some population, they develop this post cholecystectomy syndrome, means persistent bloating, diarrhea. That is, so it is not uncommon, not common to have post cholecystectomy difficulties in physiology or life. So that is why cholecystectomy in a good place, good hand, is safe if it is indicated. So this is just to tell before I go towards the conclusion, like cholecystostomy, this is what you all of you should know what happens and why we do. This is like making an opening in the gallbladder and draining it outside. This is mainly done as an emergency condition. Patient is very sick with a severe cholecystitis, where we are not able to take the patient for surgery, in a, like an ICU patient has developed acute cholecystectomy after doing a bypass surgery for the cardiac condition. So you can do an emergency even bedside. You can be ultrasound guided puncture into the gallbladder can be done to drain the toxic fluid. That's a temporary measure to make the patient better and improve, rather than taking the patient for cholecystectomy. I am not going into it because next presentation will be on this. Thank you. Any question?
Fantastic presentation, Sudeepta.
Sir.
So suppose I am elderly actually. I don't need to pretend elderly. I have a son settled in US.
Sir, you are elderly young person.
So I am going for a break, child minding duties to America. So I have asymptomatic gallstones. So I don't want to give trouble to my son. So it doesn't have medical insurance for me. I am a diabetic too. Should I wait for a complication with empyema or gallstone pancreatitis and cholangitis can be life-threatening and very costly as well, and I suffer the pain as well, and interval antibiotic, delayed cholecystectomy. Yes. So will you have a different advice to that slide in clinical practice?
Yes, sir. This is if you discuss in like detail, like what you told. That's an interesting topic to discuss actually. Sir, diabetics with gallstones. This was one of the indication for surgery earlier, not now. That time the control of diabetes was not there in most of the patients. That's why in a patient who has controlled diabetes with medication and healthy lifestyle and no other factors, it need not go for cholecystectomy for asymptomatic cholelithiasis. Knowing that this dictum was why cholecystectomy should not be done in asymptomatic cholelithiasis was done because of the burden to the health system and also the number of complication. 1.2 million that time means like 10,000 plus patient will have complication and the burden of it. But knowing that, the other, I remember Dr. Radhakrishna, sir, I was working with him one patient came for just, I'll take 1 minute, patient came for perimenopausal, I don't know sir remembers or not, perimenopausal vaginal bleeding, and during the checkup we found asymptomatic cholelithiasis. So we told no, that is important, you go for it first, complete that and assessment, then we can deal with that later, is asymptomatic. Patient underwent endometrial biopsy, he was going home, developed acute biliary pancreatitis. Landed in ICU, 7 days down, patient didn't survive, we had to leave. So, but it is just one example, we should not take this one and tell that the whole thing has to change. But this is the recommendation. In corporate hospital in healthcare, we take milder indication bloating as one cause and do the cholecystectomy. But taking it seriously, we have to. And provided you should have an extremely safe hand. If it is not safe, then the criteria is more stringent. Thank you, sir.
Sudeepta, can gallstones cause cancer?
Sir, that is the first I told, like pure cholesterol stones, more than 3 centimeter, there is a 2 to 3% chance of malignancy. Some data are there, but it's not a absolute indication for surgery. But this is considered 3 centimeter, some say 2 centimeter, pure cholesterol stones, they are carcinogenic. Or packed stones. Packed stone also causes irritation of the wall and causes malignancy.
Excellent presentation. I think he covered everything very well. Just for sake of summarizing, I would just mention 2 important points for our nursing friends here. So one, gallstones are not equivalent to kidney stones. Many patients, your relatives may come and ask you that kidney stones were there and it just passed off without any surgery. Should I get surgery if, especially if the patient is having pain? So you have to educate them that gallstones are not equivalent to kidney stones. Gallstones have to be managed differently, not like kidney stones. So cholecystectomy may be indicated. 1. 2. Again and again you will be asked this question: what happens if I get my gallbladder out? Will my digestion? How will the body digest things? Because there's a very strong misconception in the people's mind that if you take off gallbladder, digestion cannot happen. So you have to first convince yourself, very clearly understand that gallbladder is a vestigial organ. It's not essential for digestion. Okay, and 99 or almost 100% of the patients who have cholecystectomy will have normal digestion. One or a very occasional patient may have irritable bowel syndrome like symptoms, but that's not important at all. So you have to convince your relatives and patients who may be asking you, will the digestion be normal after cholecystectomy? You have to say emphatically that yes. These are 2 things we have to.
The one addition I will say is digestion of non-vegetarian food as well. So post cholecystectomy, the key question is they'll ask whether you can take non-vegetarian. That yes, the answer is a resounding yes.
Yeah,
Thank you.
Normally I tell that you may not be able to take fatty food when had a previous acute cholecystitis calculus, but once we remove, you will be able to take it. That makes them comfortable. Thank you.
I request staff nurse Twinkle to please felicitate Dr. Sudeepta.